Hello, everyone. Good evening to everyone. I am Dr. Nagraj from IIP Digital
Dr.
Media Team.
Nagraj, you need to wait for the Facebook Live. We have just connected participants on Zoom. Please give me 2 minutes. Okay?
Yeah, ma'am, sure.
Live on Facebook, then we'll start. Otherwise, Facebook audience will not be able to view. Okay?
Done, ma'am.
Thank you. Just give me 2 minutes. Dr. Nagraj, you can start. We are live on Facebook as well.
Yes, ma'am. Good evening, everyone. I am Dr. Nagraj from IIP Digital Media Team. I'll be host for today's webinar on postpartum low back pain with resource person Dr. Snigdha Mehta, being organized by IIP Women's Health Networking Committee, Maharashtra State, on the occasion of World Physiotherapy Day 2024. The Indian Association of Physiotherapists is the oldest and largest association representing physiotherapists in India since 1955. The IIP Digital Media Team consists of a group of physios who handle Zoom platform, webinars, live streaming, and IIP profiles on social media platforms like Facebook, Instagram, Twitter, LinkedIn, YouTube. Follow IIP profiles on these social media to receive notifications for our events such as webinars, workshops, CMEs, conferences, health camps, blood donation drive, and to know about recent updates on physiotherapy, subscribe to IIP YouTube channel for notification of our live webinars. In playlist section of this channel, webinars are segregated into various folders on topics like orthopedics, neurology, sports and fitness, pediatrics, cardiopulmonary, women's health, research, cancer rehab, etc. For easy access, the social media links will be shared in the chat shortly. Without much wasting time, I would like to hand over the session for the today's moderator, Dr. Moonmai Avijit. Over to you, ma'am.
Thank you, Dr. Nagraj. Good evening, everyone. I, Dr. Murmay Avset, welcome you all on the behalf of IIP Women's Health. IIP Women's Health. Now, let me just share the. Ma'am, can you please switch off your screen sharing so I can share IIP Women's Health slide, please?
You want me to switch it off?
Yeah, for a second, ma'am.
Okay. The video, no?
No, the screen share, ma'am.
Screen share. Oh, okay. Screen share. Okay.
So IIP Women's Health functions under the guidance of National Head Dr. Ruchi Vashne and IIP President Dr. Sanjeev Jha. We have 5 zones in India with heads for each zone. Dr. Pooja Kamble is the West Zone head. The state team of IIP Women's Health Maharashtra includes State Coordinator Dr. Suvarna Ganvir ma'am, Joint Coordinator is Dr. Snehal Patel, and as Sub-Coordinator as Dr. Uttara Mohan, Dr. Priya Karande, and Dr. Nirali Sanghi. We have 22 districts committees in the state. In Maharashtra, IIP Women's Health has conducted many low-cost activities like CMEs, workshops, conferences, webinars, public awareness campaigns, health campaigns, blood donation camps in various districts since 2018. In the year of 2019, 21, 22, 23, and 2024, IIP Women's Health Maharashtra has received award for Best IIP Women's Health State Team. The networking committee in Maharashtra State, working under the guidance of IIP Women's Health Maharashtra State, includes Dr. Mayura Deshmukh, Dr. Mrunmayee Outset, Dr. Smita Shinde, Dr. Ketki Patani, Dr. Krishma Pandey, Dr. Sikina Dilawar, Dr. Rutvi Gandhi. World Physiotherapy Day is a global healthcare event celebrated on 8th of September every year since 1996. This year, 2024, the World Physiotherapy Day theme is low back pain and the role of physiotherapy in its management and prevention. And on this occasion, IIP Women's Health Networking Committee Maharashtra State has organized webinar series on topic of low back pain with most eminent speakers from the different fields. Today's webinar will be addressed by senior most and eminent faculty from the field of physiotherapy, Dr. Snigdha Mehta ma'am, on postpartum low back pain. And I, Dr. Mrunmayee Outset, will be the moderator for this webinar. Before we proceed ahead, I would like to introduce our today's speaker, Dr. Snigdha Mehta ma'am. Dr. Snigdha Mehta ma'am is an alumni of prestigious GS Medical College and All India Institute of Physical Medicine and Rehabilitation, Mumbai, and has her own physiotherapy and pelvic wellness center in Juhu, Mumbai. She is the only physiotherapist in India to have received certification from APTA in obstetric and pelvic health physiotherapy in advanced pregnancy, postpartum physical therapy, advanced techniques in labor support, incontinence, pelvic pain, bowel dysfunction. She is the first Indian physiotherapist to receive scholarships from the American Physical Therapy Association and the only one ever to be featured on their website. She has also received training from renowned physiotherapists like Brian Mulligan, Shirley Sermon, Jenny McConnell, Michael Shacklock, Paul Hodges, and many others. She has more than 40 years of experience treating patients and educating students across the globe. She was invited as an observer by Christopher Powers to the University of California. University of California. Hence, I welcome Dr. Snigdha Mehta ma'am and IIP Women's Health members, networking committee members, and all the delegates who all are attending this webinar. Now, I request Dr. Snigdha Mehta ma'am to please start the enlightening session we all are waiting for.
Should I share the screen now?
Yes, ma'am, I'll stop sharing. Can you now share the screen?
Yeah. Yeah, okay. It's not coming, no?
Ma'am, the slides are there. You just have to start the slideshow.
Yeah, that's what I'm doing.
Ma'am, you can click on resume slideshow. Yeah, there only.
Left
I
side.
did on
first up.
slideshow. That's what I did
No,
on
no, ma'am,
slideshow.
down. Resume
And then
slide.
from current slide. It should
Yes.
normally come, the full
Right.
screen
No.
should come, right?
No,
Yes,
ma'am,
ma'am.
you
Now you can
click
click on the resume slideshow.
Okay. Yeah, yeah, this is fine now.
Yes.
Okay.
Done.
Okay. Thank you so much, Dr. Mrunmayee, for that wonderful introduction. It's such a pleasure to be here today. Thank you so much, Indian Association of Physiotherapists, for inviting me Thank you so much for President, Zonal Coordinator, Maharashtra State and National Coordinator of Women's Cell. I'm so proud of the work that all of you are doing, and I'm so happy to be here today. Today I'm going to talk, as Dr. Mrunmayee said, about postpartum low back pain. This is a very beautiful period in my life. I've been doing this for almost 40 years, and I have so many, I've produced, I would say, so many young, beautiful children. And it's a very emotional work, of course, with all the other practical knowledge, etc. But it's a beautiful work that we physiotherapists have started doing. When I did it 40 years ago, there was hardly any knowledge about this. But as the days went by, now I find that all over India, this particular branch of physiotherapy has proliferated, and we have some renowned people who are doing this work now. So thank you for listening to me for the next few minutes. Yes, pregnancy has a profound effect on the human body, particularly on the musculoskeletal system, of which we are always concerned. So in this talk, I'm going to tell you a few points that I would like to mention here. What is the definition of postpartum low back pain, the prevalence, the etiology, assessment and diagnosis, and management. My whole talk will be on my experience of 40 years, and also evidence-based physiotherapy, of course, is a must at every stage. So low back pain during pregnancy and postpartum period has been known and recognized for many centuries by some of these great people. And it may be a continuing system of pregnancy, or it would develop as a new system after labor and delivery. Yes, postpartum low back pain is usually defined as pain between the 12th rib and the gluteal fold. What is the prevalence? So there is a plethora of studies regarding the epidemiology of pregnancy-related low back pain. Rates range as frequently as 25% to 90%, with most studies estimated that 50% of women suffer from postpartum low back pain. A very interesting study done in India by a very eminent person in Gujarat. As I read that paper, I was intrigued by it, that in women with normal vaginal delivery, almost 33% women have low back pain, whereas those have C-section have much more, up to the 56.67% of low back pain. The lumbar region, the pain is more in the lumbar region. The lumbar pain is more in the lumbar region, and the pain in the, one second, I'll just put the pointer, yeah. So in the lumbar region, and the pelvic region is below the iliac crest and up to the gluteal fold. To be more specific, from the iliac crest to the gluteal fold is what you call of the pelvic girdle or the sacroiliac joint pain, and it could be together with the symphysis pubis pain. This pelvic girdle pain can also be felt in the groin and posterior thigh. When both lumbar and pelvic girdle pain, as is present in some women, it is called the lumbopelvic pain, LBPP. And the peak of LBPP intensity generally appears between 24 and 36 weeks of pregnancy. And women suffering from this during pregnancy will still experience LBPP beyond 3 months, 33% of them, and beyond 12 months also sometimes. However, when pain is present in both the lower abdomen and low back, it is usually of a gynecological origin. So we are talking of only back pain and pubic pain at the most, but we are not talking of lower abdominal pain. What is the etiology? Yes, it's like loading the gun. So the gun is all there. We can't do anything about it. So what are the causes? So normal weight gain during pregnancy, which is expected in all women, increase of the abdominal sagittal diameter and the consequent shifting of the body gravity center anteriorly increases the stress on the lower back. Axial loading on the intervertebral disc is another cause, and ligament and joint laxity is another cause, which in the relaxin hormone increases tenfold in these people. A weakness of gluteus medius is an interesting study done in many papers. And I have also my experience that a lot of these women have a weakness in the gluteus medius. Abdominal strain, of course, is another reason. Body mass index greater than 25 pre-pregnancy, end pregnancy, and 6 months after pregnancy is another reason. Previous history, now the gun is not only loaded, but it is also got the trigger. So it can, it adds up to the problem. If your body mass is less than 25, you're less likely to get, but if it's more than 25, if you have a previous history of back pain, if there have been multiple pregnancies, if you have had a sedentary lifestyle or a physically very heavy work, they also are precipitating factors for low back pain during the postpartum period. Okay, now the strained abdominal muscle, bending and lifting the baby, poor posture during breastfeeding, carrying the baby the wrong way without proper support, returning to high impact exercise too soon after deliveries are added factors to which we women contribute and make our pain worse. There's an agreement, however, especially at the European guidelines for diagnosis and treatment of pelvic girdle pain, that contraceptive pills, time interval since last pregnancy, height, smoking, and most probably age are not considered risk factors for low back pain during the postpartum period. Other causes of postpartum pain are very interesting, is pregnancy and lactation associated osteoporosis. And the risk factors include low BMI, physical inactivity, poor nutrition, and insufficient calcium intake, which we do see in a lot of people, and we have to keep that in mind. If there's spinal stenosis or if there's a sciatica, disc herniation, stenosis, piriformis syndrome, any of these cause sciatica, then also we may get low back pain. So in 1962, Walday was the first to recognize the differences between pregnancy and postpartum pelvic girdle pain and lumbar pain. Later, Ostgaard set the criteria for differentiation between these two entities. So I would divide the low back pain in the postpartum period into three parts: the lumbar pain, the pelvic girdle pain or the SI joint pain, and I would add to it, which most authors don't talk about, is coccydynia, which we also see not very infrequently in many women. So lumbar and pelvic girdle pain can be diagnosed and differentiated with each other by history taking, clinical examination, provocative test maneuvers, and imaging. And management ranges from conservative and pharmacological measures to surgical treatment. So when a patient comes to us for physiotherapy, we always take a detailed history and do a thorough evaluation as always. In this case, the low back pain, we should find out what is the pre-pregnancy low back pain and the history of low back pain during pregnancy. Also, the type of delivery is important, whether it was vaginal. If it is vaginal, was an instrument used, or was it a C-section or a cesarean? And may also have all these may have a role in postpartum backache, or if there are any comorbidities that the patient is having. So in case of lumbar pain, activities such as bending down, lifting the baby, sitting on bed or soft couch, standing could be reasons for increase of the pain. Let's talk about lumbar assessment. We all are very familiar with, so I'll quickly run through it. So location of lumbar pain, as I earlier said, is in the lumbar region above the sacrum, and can sometimes, especially in the lumbar region above the pelvis, and sometimes it can radiate to lower limb right up to the foot, especially if there's a radiculopathy. So to find out the difference between whether it's a pelvic girdle or a SI joint pain or it's a lumbar origin, we do a passive SLR. We do a passive SLR with dorsiflexion. We do it with internal rotation and then raising or flexion of the head and neck. On the basis of that, if any of the symptoms are reproduced, then we can put it down as lumbar pain. We additionally do a slump test. And of course, we have the McKenzie way of assessing the lumbar spine. This is what I always do in my postpartum women, the lumbar segmental instability test. So we put the patient prone on the bed and then palpate the intervertebral motion passively at various lumbar levels with the hypothenar eminence on the spinous process. And if a particular segment is located which is painful, we ask the patient to lift the legs off the floor. And if the pain decreases when the legs are lifted off the floor because of the action of the back muscles, then we consider that a positive test for lumbar instability. What about the pelvic girdle or sacroiliac joint pain? So this particular European guidelines talk about pelvic pain that arises in relation to pregnancy, trauma, arthritis, and osteoarthritis. Pain is experienced between the posterior iliac crest and the gluteal folds, particularly in the vicinity of the sacroiliac joint, and the pain may radiate in the posterior thigh and can always also occur in the devices. PGP is 4 times as prevalent as lumbar pain in postpartum women, so it is much more common. It typically presents as uni or bilateral aching pain below the L5 level without numbness or paresthesia. If there is a lumbar pain, there may be or may not be numbness or paresthesia, but in pelvic girdle origin pain, there is not a numbness or paresthesia usually. And this pain can radiate up to the posterolateral thigh, to the knee and calf, but not to the foot ever. What are the aggravating factors or what are the symptoms of a pelvic girdle pain? Walking, especially walking briskly, walking for a long time, putting weight on one leg at a time. Like for example, when we climb stairs, when we get out of the bath, when we do dressing, wear our trousers, parting our legs, for example, getting in and out of the car, they are typical symptoms of pelvic girdle pain. Twisting, such as turning in bed, repetitive bending ADL, and lying on your back or side. Especially if the upper leg, when you lie on your side, is not supported at night, they get typical symptoms of sacroiliac joint pain. Palpation tests, X-rays, CT are not recommended as diagnostic criteria for pelvic girdle pain. MRI may be used to exclude ankylosing spondylitis, and in the case of positive red flags, it should be taken if we have a doubt. This was an interesting study, and most women recover from pregnancy-related lumbopelvic pain within 3 months of delivery, at the most 6 months. But because the biomechanical and hormonal changes from pregnancy are largely reversed by 3 months. But if the pain continues after that, then it could be assumed that there are other factors that could be interfering with the recovery. And we have to find out what are the factors that could be preventing the recovery of the pain. Usually the patients, when they say I'm getting pain, they point it out with one finger. It's a very typical thing. Lumbar pain, they will never show one finger, but in pelvic girdle pain, often they'll show one finger. This is where I get the pain. So to diagnose it, there are a whole battery of tests we do. First, I'll talk about the functional load transfer test, that is the active SLR and the stock test. And this tests the ability to transfer load between the lumbosacral spine and the legs. So this is the stock test. You ask the patient to put equal weight on both the legs, and one thumb palpates the PSIs and the other the S2. And then you ask the patient to lift the contralateral leg. Normally, the sacrum goes cephaloid to the PSIS, but if it is positive, then that does not happen, and it indicates failure of self-bracing mechanism to maintain the sacroiliac joint in a closed packed position. Similarly, the active straight leg raise test is also an indication for dysfunction in the ability to transfer loads between the lumbar sacral spine and the legs. Now, in addition to the active straight leg test, if you apply force to support the pelvis and the patient lifts the leg and they feel that their symptoms have reduced dramatically on especially the symptomatic side because of the external support that we have provided, it would again indicate there's a load transfer dysfunction, and this is very common in my postpartum women. So Dan Lee has noted that the location on the pelvis where compression reduces the effort to lift the leg is very important. It helps us to plan which exercise would help the patient the most. For example, if the compression is on the anterior part of the pelvis at the level of the ASIS, it simulates or reproduces the force produced by contraction of the lower fibers of transverse abdominis, and compression of the posterior pelvis at the level of PSIS simulates contraction of the sacral multifidus. So if compression on the anterior pelvis is decreasing the symptoms of lifting the leg actively, then we have to focus on working on the transversus abdominis. And if it is on the posterior pelvis, the compression reduces the symptoms, then we need to work on the sacral multifidus more. Some provocation tests of SIJ. These are some of the provocation tests that we normally do, and I'll go through them one by one. Posterior pelvic pain provocation test. In that, we lift the hip by 90 degrees and stabilize the ASIS on the contralateral side. And if by giving a vertical compression to the ipsilateral knee, we get reproduction of symptoms, then it is indicating toward a SIJ source of pain. The thigh thrust test is a little more forceful, and if the earlier test was negative, then we do the thigh thrust test, and we stabilize the sacrum, and pressure is applied dorsally along the line of the femur after the hip is slightly adducted. And again, if you get concordant symptoms in the SIJ region, then it is a positive for SIJ. All these tests have good positive and negative predictive value and sensitivity and specificity. The anterior distraction test can also be done. Posterior compression test, again recommended by Diane Lee, is also indicative. If it reproduces the symptoms, then it indicates symptoms of SIJ. You not only give the pressure, but you hold it for 5 seconds to distract the anterior aspect of the SIJ and compress the posterior. And if it is on the sideline position, we give an anterolateral aspect of iliac crest is palpated by the hand, and slowly a medial force is applied through the pelvic girdle for 5 seconds to distract the posterior aspect and compress the anterior aspect of SIJ. A positive test would show reproduction of SIJ. Matrix Faber is another very useful test. If the pain is reproduced posterior to the hip, then it must be positive for SIJ. But if the pain is reproduced in the anterior part of the hip, then it would be positive for hip pain. The Gensler's test is another very useful test, and we extend the hip on the affected side or the symptomatic side, and if it reproduces symptoms, so for example, in here we have the right hip completely flexed and the left hip extended, and if there are concordant symptoms, it would indicate a pelvic girdle pain. Long dorsal or posterior sacroiliac ligament palpation is a useful palpation, and you make the patient lie prone and palpate slightly caudal to the PSIs where you see the long dorsal sacroiliac ligament. If it is tender, then in addition, you can counternutate the sacrum with the other hand, and this will increase the symptoms of pain. Then it indicates SIJ problem. So this was a paper done on the long sacroiliac ligament test, how useful it is. And it confirms that the long dorsal sacroiliac ligament frequently shows tenderness on palpation in patients with peripartum pelvic pain. Sensitivity was 76%. And when only severe pelvic patients were included, the sensitivity was as high as 98%. So it is definitely a very sensitive test to diagnose a sacroiliac problem. The conclusion was that the combination of the active straight leg raise, the posterior pelvic pain provocation test, the long dorsal sacroiliac ligament pain test, when combined, seem promising in differentiating between mainly lumbar and pelvic complaints. So this cluster of tests have a very good positive predictive value, but the negative predictive value is extremely high, 96%. So if you check the patient and none of these are positive, then it is definitely not a pelvic girdle problem. And the sensitivity and specificity is also quite high. So typically SIJ is diagnosed when at least 3 or more pain provocation tests are positive. What are the other causes of posterior pelvic pain? There could be pathologies like the spondyloarthropathies, which could be causing the pain. We have to know that there are other things other than mechanical or musculoskeletal causes of pelvic pain. We have to be aware of that. Posterior femoroacetabular pathology could be another thing. Proximal hamstring tendinopathy, piriformis syndrome. So if piriformis is tender, then and if the Faber's test is also positive, it could indicate the piriformis syndrome. Stress fracture of the sacrum, very rare entity, but could be one of the things we have to be aware of. And of course, referred pain from the lumbar spinal pathology, which could include the lumbosacral facet-mediated pain, and proximal L5 radiculopathy is to be considered as an overlap of the pelvic girdle pain. So the diagnosis of SIJ pain is a multifaceted process that involves a careful assessment, and we must focus on the history, observe the gait pattern, perform the key physical examinations that are provocating maneuvers that I just talked about, and then plan the physiotherapy treatment. When we plan the physiotherapy treatment, we have to do the evaluation and identify the affected lumbopelvic and hip muscles, which would improve her ability to transfer loads effectively between the lumbosacral spine and legs. So next we do a muscle evaluation of some of the affected muscles that could be responsible for the pelvic girdle pain. There was a study done on the importance of stabilizing exercises for pelvic girdle pain. And the people, 81 women were divided into 2 groups, and the exercises were done for 20 weeks. So one group received physical therapy with a focus on specific stabilizing exercises, and the other group received individualized physical therapy without specific stabilizing exercise. In both groups, the exercises are very individualized and specific, but in one there was a stabilizing exercise added, in the other they were not added. So the conclusion was an individualized treatment approach with specific stabilizing exercise as part of a multifactorial treatment appears to be more effective than physical therapy without specific stabilizing exercise for women with pelvic girdle pain after pregnancy. These are some of the muscles we must test. I'll not go into details because of lack of time, but we all know these muscles. These are the important muscles, the local stabilizers. And then we have the global stabilizers that could affect the pelvic girdle pain. And then the global mobilizers. So how do you prevent postpartum low back pain? First of all, we must take care of the woman in pregnancy itself. In my opinion, if you look at all the papers, they mention of postpartum pain as at least 50% average. In my practice, I find that if we take care of them of the musculoskeletal system during pregnancy itself, or even better in the pre-pregnancy before they conceive, then very, very few percentage, maybe at the most 5 to 10% at the most, will have a low back pain in the postpartum period. So that is what is most important. And of course, if they do already have, then evaluation and identification of the affected lumbopelvic and hip muscles is extremely important. And facilitation and retraining of the dysfunctional local and global lumbopelvic and hip stabilizers is what we have to do. And inhibition and regaining extensibility of the dysfunctional global mobilizers is the other thing that we have to keep in mind. We start with the local stabilizers, then go to the global stabilizers, and then we do the inhibition of the dysfunctional global mobilizers. In addition to this, manual therapy techniques within the precautionary framework necessary for postpartum women can be done, and this could include soft tissue mobilization, myofascial release. Also, anatomy trains is another thing that I have recently been introduced to. It's a wonderful way of treating and managing low back pain. Manual mobilization, Mulligan, Maitland, etc. Muscle energy techniques, patient education, very important for lifestyle and biomechanical modifications, and sacroiliac joint belts if necessary. There's a consensus which has been reached by an international Delphi study about common musculoskeletal impairments in postpartum runners. And I feel this is equally important in all the women that we see. So the range of motion impairments that you commonly see in these women are hip extension restriction, anterior pelvic tilt restriction, and general hypermobility. The alignment impairments that we see in these women is Trendelenburg sign positive, dynamic knee valgus. That means they go into knee valgus at certain times when they walk, they climb stairs. They have a hyperlordosis very often, lumbar lordosis, and overpronation of the feet and thoracic kyphosis, which adds to the problem. As far as the flexibility impairments are concerned, very often they have an abdominal wall laxity and also tightness in hip flexors, lumbar extensors, iliotibial band is tight, and often the hamstrings are also tight. The risk factors for pain in postpartum runners were muscular imbalance, and which I find is, this study was done on runners, but I find that in most of my postpartum women, that muscular imbalance, poor lumbopelvic control, and too much too soon, especially amongst athletes, but also in our women trying to lose weight, they start Zumba and running and all these kind of exercises too much too soon, and they end up with low back pain. Also, life stressors, pain during pregnancy, and pelvic floor trauma also are risk factors for low back pain. What is the prevalence of low back pain experienced after delivery with or without epidural? So these are some interesting studies that I came across, and I would like to talk about them. So this was done on 460 women. Out of that, 230 women received epidural and 230 did not receive. So you often come across, I'm sure all those who are doing this obstetric work come across women and family and the patients themselves and their relatives asking you why the postpartum back pain is perceived when you give the epidural. It is perceived as a lifelong damage to the spinal cord because of epidural analgesia. The conclusion of this study was there was no association between the epidural analgesia and postpartum backache. This is a concern with a lot of women. That's why I put this paper across. And then there was this other interesting paper on the on DRA, diastasis recti. Women with diastasis recti at 6 months postpartum were not more likely to report lumbopelvic pain than women without DRA. This was another interesting study. So early menarche, that means if the girl got her period at a very early age, she was more likely to be having pelvic girdle pain later in her life. Emotional stress is definitely a contributive factor for women who do not recover from low back pain 6 months after delivery. So the presence of emotional stress during pregnancy is independently associated with the persistence of pelvic girdle pain after delivery. Breastfeeding was definitely beneficial for those who, especially who are not obese or overweight. And those who have pelvic girdle pain, highly recommend and encourage that they should continue breastfeeding. This was study done on pregnancy and lactation associated osteoporosis. Who had persistent and severe low back pain and height decrease associated vertebral fragility fractures. This rare and clinical entity must be kept in mind in differential diagnosis in postpartum women presenting with low back pain. The most important telling sign, which you can see very easily before they get the fragility fractures, is the height decrease. So if your patient comes to you with severe low back pain, but with also height decrease, keep in mind that lactation associated osteoporosis could be the reason for the low back pain. What are the red flags and when should you refer? While postpartum back pain usually resolves on its own after a few weeks, severe pain can also indicate an underlying neurological problem or even an infection. If you notice any of the below signs, you must refer immediately. If back pain is severe, constant, or getting progressively worse, if it was caused by trauma or is accompanied by fever, if patient loses feeling in one or both legs or suddenly feels uncoordinated or weak, and if she loses sensation in her hips, groin, or genital area, immediately please refer back to the appropriate doctor. A little bit about Coccydynia, which I said I would like to add. Are we okay with the time, Murunmai?
Yes, ma'am. We have.
Okay. So Coccydynia is normally not put in the most of the researches that are done on low back postpartum pain. But it is an entity which is not uncommon. So postpartum coccydynia can occur when the coccyx is forced backwards beyond its normal range of motion due to physical stress on the coccyx during a difficult vaginal delivery. The symptoms are localized pain and tenderness around the coccyx, which can intensify when sitting or under direct pressure. As the woman, when she breastfeeds, they have a severe pain. And discomfort can also happen with bowel movements. So what are the risk factors for postpartum coccydynia? A very large baby, an unusual baby position, a narrow pelvis, a history of previous repetitive micro trauma, for example, from incorrect sitting before even she conceived. For example, the sports people, the ones that take part in the triathlon, and who regularly do cycling for hours or take part in the competitive cycling, I find that they are more likely to have this kind of pain. And difficult or instrumental delivery can also cause coccydynia. A short perineum can also cause coccydynia. So how do you assess coccyx? It is better if you don't have the clothes on, but for pictures, I have kept them on. So patient is in a neutral posture. Use your middle finger to follow the sacrum up to the coccyx and assess whether the coccyx is anterior, posterior, lateral, or rotated. And we can do the coccyx flexion test. So ask the patient to do a lumbar flexion or a posterior pelvic tilt. When you do that, for all people, normally the coccyx will flex. And then you ask the patient to do a pelvic floor muscle contraction and note whether the coccyx moves normally anteriorly or whether it flexes or not. For the coccyx extension test, you either ask the patient to do an anterior pelvic tilt or a lumbosacral extension. And similarly, you ask them to bear down the pelvic floor and note whether the coccyx moves posteriorly or extend. Now, if you find that that does not happen, then how do you manage postpartum coccydynia? First of all, avoid sitting on a donut ring cushion, as this will allow your pelvic floor to drop. A very commonly given prop for coccydynia is not recommended, because it causes increased buildup in the pelvic floor area, which is detrimental to the coccyx as it is attached to the coccyx. Instead, use a wedge cushion which leaves a space for your coccyx only. It is preferable. Also, the patient must be asked to sit more upright, evenly on both the ischial tuberosities, which they sometimes don't do because of the pain, and the hip should always be higher than the knee when they are sitting down. Suppose the coccyx is stuck in extension or lacks adequate flexion, then how do you mobilize it? So ask the patient to slowly slump and contract the pelvic floor muscle. And a therapist holds the coccyx in flexion, because the coccyx will go into flexion, and then ask the patient to relax the contraction. Repeat 3 times, and the therapist takes up the slack each time and gently guide the patient back to neutral. This is if the coccyx lacks adequate flexion. If the coccyx lacks adequate extension, you first you think of a stuck drawer. So if you have a drawer which is stuck, you usually, what happens, you will not pull it. You will just push it first and then pull it, right? Everybody agrees? Okay, so that's exactly what we do with the coccyx. First, we flex it, okay? So first perform the flexion mobilization. After the third pelvic floor muscle contraction, use a finger to contact the to mobilize the coccyx superiorly and posteriorly into extension. So first you push the coccyx into flexion, and then you bring it into extension. You can do rigid taping for coccyx that is stuck in flexion, and it helps to maintain the extended coccyx. Let me tell you this case report. A 31-year-old female complained of low back pain since the birth of a second child 11 months earlier. And subjective and objective examination led the therapist to consider a diagnosis of sacral stress fracture, which was confirmed by MRI. So we have to keep this in mind. It could be not just coccydynia, it could be a sacral stress fracture that could be the case with the patient. 3 months after presenting to physiotherapy, the patient was pain-free and had returned to all aspects of her daily life without any difficulties. So early intervention made the patient much better, but if we miss it, it can get worse. So yeah, we must be aware of these uncommon, I would say, pathologies. So sacral fracture incidence is not known very much, but there are a number of cases reported in the literature, which you see. So there must be so many people who may be getting sacral fractures. We all have different, favorites. So we have studied in detail any of these great pioneers of physiotherapy in the world, and we like to use this method for evaluation and treatment. It could, for me, these are the few that I have trained with. That's why I mentioned, but there are many others whom you could have trained with, and you like to use those methods for evaluation and treatment. And what I would say is all approaches shown by different physiotherapists of these eminent physiotherapists have their strengths and limitations. Choosing which approach to use tends to depend on your learning experience during your time as a student, as well as a clinician or as a teacher. What do? I usually, all approaches can be adapted and used in combination, and that's what I do. So allowing a thorough assessment and diagnosis of patient's problem, looking at both the mechanical, structural, and movement impairment. So the more you learn, the more tools you have to assess and diagnose a patient's low back pain during the postpartum period. In conclusion, I would like to say that a history of pregnancy and childbirth is a risk factor for chronic functionality, significant back pain in women, and severe acute postpartum back pain is a risk factor for future disability. Hence, the peripartum period may provide an important opportunity for intervention, so early recognition and management may mitigate future disability. This is something I learned from Dr. Christopher Paz. He once told me, and I follow it today. So if you practice today what you did yesterday, then you should be out of practice. That means we have to keep learning. Every day we have something new to learn. And that's what our physiotherapy profession is all about, and we are proud of it. These are some of my research papers whom I have referred to, and thank you so much.
Thank you, ma'am. Thank you. Anyone has a questions, please drop in the chat box if you want to ask any questions to
Let's stop
ma'am.
share.
And if the people who are watching through Facebook Live, if they have questions, please put your questions through Facebook Live in your chat box. We will ask ma'am. We will wait for 1 minute, ma'am, if any questions are there.
Mm.
Ma'am, there is one question. How long usually rehab should last after postpartum for back pain, usual back pain?
Sorry, can you say it again?
How long usually a rehab should last after postpartum, especially a patient suffering with low back pain?
How long? Till the pain goes away, unless it's not a mechanical. If it's a mechanical pain and we are sure of the diagnosis, then till the pain goes away. Right? We have to wait, and that differs from person to person. So, but we have to make sure if it's, first of all, we have to be sure it's a mechanical pain. We are not talking of non-mechanical pain. So if you have a doubt, refer. But if you are sure it's a mechanical origin and we can treat it, then definitely we can go about it for almost a year. But normally it becomes better much sooner than that.
There is one question, ma'am. In case of LSES, when should we start giving the treatment, or what should be our first line of treatment?
For low back pain?
I think so, because she has not particularly mentioned, but I think yes, ma'am.
If there's a cesarean section and if the patient has low back pain, that I'm glad she asked the question. One of the things which I didn't mention here, I would do a scar tissue mobilization. I would check the scar of the patient and do a scar tissue mobilization, and that could be the game changer for relief of pain.
Okay. What role core muscles play when it comes to low back pain? I personally have attended your sessions, and you've been enlightening us a lot about core muscles, how they are important in strengthening during pregnancy. Including diastasis recti check or transversus abdominis particularly. So can you just enlighten about that particular part?
The role is very important, of course, especially in the postpartum period. So definitely we evaluate not only the transversus abdominis, the multifidus, and the pelvic floor. Pelvic floor, of course, we can, if you are a pelvic health physiotherapist, you can evaluate from inside, internal palpation. Even the coccyx, coccydynia can be treated from internally. But also we have to look at the breathing. Breathing is extremely important. The movement of the diaphragm, the excursion of the diaphragm is extremely important for the patient. And so we usually begin with these muscles. Once these muscles are in a facilitatory position first, depending on what the strength is, and then we put them in challenging positions and different positions, and then we also at the same time start with some of the global stabilizers, and then we also look at the global mobilizers, which could be the reason why the patient is not able to. Suppose she has a piriformis that's tight, suppose she has a hamstring that's tight, suppose she has a calf that's tight. So everything is interrelated. So when we do the checking of all the muscles, we should do of all the muscles and then select how we should go about it. But yes, you start with the local stabilizers before you start with the other global muscles.
So a lot of questions are coming, ma'am. Can we prescribe quadratus lumborum strengthening and pelvic floor muscle strengthening after C-section within 6 to 8 months?
Pelvic floor strengthening, you can start from very early. You don't have to wait for 6 to 8 months. Okay. So it's after a C-section, especially, she said, right?
Yes, yes.
Yeah. But even if it's a normal delivery, we start very early within the comfort of the patient. We never force any patient to do anything. So within the comfort of the patient, we start on day 1, day 2, day 3, all these gentle exercises. In fact, if they start moving those muscles, the pelvic floor, the transverse abdominis, the breathing, these are the 3 things that we focus on even on day 1, day 2, day 3. So it's not as if we wait for so long to focus on them. And then we look at the symptoms of the patient. So if they don't move those muscles, then is the problem. If they move the muscles, then it's less of a problem. The rehabilitation is much faster.
Uh, can we take one more question, ma'am?
Yeah.
How do you relieve a breast engorgement as well as related upper back pain?
Breast engorgement and upper back pain?
Yeah, related upper back pain.
So breast engorgement could be unrelated with an upper back pain, or it could be just that the breasts are heavy and therefore they have upper back pain, or it could be the posture is such and therefore they have upper back pain. So it could be related or unrelated, not necessarily always related.
Okay. Okay. Do you give any home program and long-term rehabilitation to such low back pain cases postpartum to prevent recurrence? Is prolapse is seen in such cases or any other injury?
Yeah, of course, home program is very important. Yeah, of course, home program. So what you teach them, you have to do at home. So yes, long-term home program is very important.
How do we manage upper back pain along with low back pain, as many patients complains of the same during postpartum?
So nothing in body is unconnected. Everything in body is connected. So very often, she is absolutely right. The person who's asking, very often, that's because the topic was low back pain. I didn't mention anything about upper back pain. Otherwise, it'll go on and on. So, lower back pain is very often associated with upper back pain. It's because of the posture. The spine becomes more curved like this. You see, rather than mild S curve, it becomes a further S curve. So specifically for the upper back pain and lower back pain, the posture for breastfeeding is very important, and also exercises for both simultaneously is very important.
Okay. I think we have covered most of the questions here, ma'am.
Okay.
So, shall we conclude the session, ma'am? I shall, it was very insightful session, ma'am, and which can't be concluded without acknowledging the people who took those efforts to make it possible, because it was a big team who helped us. I would like to take a moment to extend our heartfelt thanks again to Dr. Sanjeev Jha, President of IIP, Dr. Bruchi Vashne, ma'am, IIP Women's Cell National Head, Dr. Pooja Kamble, for granting us the permission to conduct this event. Their willingness to allow us to host this event reflects a great deal of trust and confidence, for which we are sincerely grateful. I extend my deepest gratitude to Suvarna Ganvir ma'am, State Coordinator IIP Women's Cell Maharashtra State, for her valuable guidance and support throughout the process. Her expert advice has been instrumental in shaping our approach and achieving our goals. I appreciate the support given by Dr. Uttara Mohan, Dr. Priya Karande, Dr. Nijala Sangvi, State Sub-Coordinators, IIP Women's Cell Maharashtra State, for their constant supervision in framing and exhibiting the concept for this webinar series. I also appreciate the efforts of all the team members of Networking Committee, IIP Women's Cell Maharashtra State, for the coordinated work as a team, resulting in a successful event. Without our digital team, it was impossible to reach our audience. So special thanks to our digital team head, Dr. Ruttara Mohan ma'am, for her extraordinary efforts, and Dr. Nagraj for the digital team who hosted this webinar today. Once again, my heartfelt thank you to our distinguished speaker, Dr. Snigdha Mehta ma'am, for delivering such an engaging and informative session on postpartum low back pain. Your expertise have provided us with valuable knowledge. Last but not the least, our audience, we are incredibly grateful for your enthusiastic participation and thoughtful questions you shared. Thank you all for your support and involvement. We look forward to see you at our future events and continuing our collaboration. Thank you so much, ma'am. Thank you and take care.
Thank you. Thank you so much, Dr. Mrunmay, and the whole IAP team, starting from the president down to each and every member and all those who helped organize this webinar today. Thank you.
Ma'am. Thank you. Thank you, ma'am.
So leave